Hi, everybody. Thank you so much, Kelly. So, as she said, I'm Caitlin Allen. I'm an occupational therapist who's both licensed and practicing in upstate New York. And I'm so excited to be here with you guys today to talk about rural resilience and how we can address trauma and mental health in the older adult population. So, with today, our learning objectives is to understand the unique mental health challenges that could be faced by this community, recognize the effects of trauma within the population, learn to implement a trauma informed care approach, assess and address the barriers to mental health care, and how we can adapt our services to meet the evolving mental health needs of the community. So, before we can even start talking about mental health trauma, that all begins in the brain, right? So, how does our brain even change as we begin to age? Well, our brain actually begins to shrink as early as our 30s to 40s. The brain outer lining surface can thin, which would lead to fewer neural connections and slower thinking. This can also mean slower processing times. When the hippocampus and the frontal lobe shrink, this can even cause changes to our behavior and our memory. The blood flow to our brain may decrease, and the neurotransmitter production can change. This can impact us not only cognitively, and therefore impacting our physical like abilities, but also our emotional functioning and our even our emotional regulation. And there's also an increased likelihood for brain inflammation, which can lead to irreversible brain damage if not treated. So this sounds like the brain is ever evolving and changing. It's not a stagnant organ. So when we think about mental health, this is a chronic condition. A mental health disorder is treatable, but it's not curable. Therefore, our treatments and how we're responding to that should be monitored and work to change to best fit that individual and their needs. So there's actually some mental health disorders that are more likely to develop in adulthood. Now, these can include things like depression and anxiety, but also dementia. And when we talk about depression, it's actually one of the most prevalent mental health challenges that an older adult may face. And its negative outcomes will affect them both not only cognitively, but it can also then lead into their physical performance. Did you know that suicide rates of men over the age of 70 are the highest of all demographic groups? Because I didn't know that until I was researching for this presentation. And suicide attempts by older adults have a higher likelihood of being lethal for those individuals. So when we look at that 65 and older population, about 14% of them live with a mental health disorder. And if you know anything about mental health statistics, we know that they're always highly underreported. So what's kind of a challenge for that? When we're looking at mental health challenges, the elderly, especially those in a rural population, have a harder time for entry. Now, when I say that, what I'm talking about are the four big A's: the accessibility, the availability, affordability, and acceptability of not only mental health disorders, but mental health treatment. So, when we talk about accessibility, that's actually the individual's access to gaining mental health care. So we know that in rural communities, there's just fewer providers per capita all across America. And then when we look specifically at the mental health practitioners, 65% of rural counties lack a psychiatrist. 81% of the rural counties lack psychiatric nurse practitioners. 47% of rural counties lack a psychologist, and so, what is that really meaning? Right now, these people have to probably travel further distances to go and see these providers who can help them with what they're going through. Now, there's also a lack of public and private transportation, specifically in rural areas. If you're someone over 65 and let's say you can't drive, how are you getting to these doctor's appointments? Working in an older adult population, I have people who tell me that they need to kind of almost prioritize. Do they, if inpatient or like in-home services aren't available, they have to prioritize if they're getting, this doctor's appointment over that one because maybe their daughter's only available to drive them for one appointment and not both. So, where does this mental health uh, the doctors scale on that list for them? And often it might be towards the bottom, especially if they have more pressing health concerns like cancer or a neurological condition or diabetes where they're needing to go for possible treatments. So now let's also talk about availability. So we know that there are fewer doctors who can treat these things in a rural county. So that means the patients who are seeking them have to wait longer for their appointments. And like I said earlier, they're traveling those longer distances to receive them. Now, that also means that those practitioners who are practicing in rural areas are seeing an influx of patients. And these practitioners might be seeing, they're treating those longer distances, so they're seeing all of those more patients. And so what this can mean is that, they're given a very short amount of time. Many, especially if you're going to like a primary care physician, they might only be given 30 minutes to deal with all of your needs and concerns for that day. And if you are someone who may be elderly, you may have multiple comorbidities, meaning you have multiple diagnoses that your practitioner now needs to work through. And sadly, mental health conditions and challenges kind of fall to the wayside. Let's say you have a new diagnosis of cancer and you find that you're getting weaker and family members are sick and you're telling your doctor that you have more symptoms of depression. Well, your practitioner may be like, well, that's normal for the given circumstances, and keep moving on rather than diving deeper into trying to address that. Now we can also talk about affordability. 1 in 5 adults over 65 report having medical debt, and 7% of the elderly population have completely unpaid medical bills that total over $54 billion. And this number is expected to continue to rise. And now let's chat about acceptability. We know that mental health challenges come with a stigma, whether that should be there, which I do not think it should. There's just a truth to it that there is this kind of thing around mental health where people don't want to be known for suffering with these conditions. So that's really going to impact these people's likelihood to go and seek treatment or even discuss these challenges to begin with, especially when we're talking about elderly, that we're talking about, the generation of rub some mud on it, pull yourself up by your bootstraps and keep moving. Now, when you even look at that in a small community, that rural community where they might know, they might have been friends with their doctor's grandma, or they've known the nurse since they were a little kid. They may have perceptions or a lack of faith in the confidentiality and the professionalism that could be happening within the practices for the population that they're serving. So, what are some factors that are affecting people's mental health? It's not only just mental health challenges and disorders, but there's so many intricate factors such as comorbidities, like I chatted about. Do they have other health diagnoses that are then impacting and playing into the overall mental health of the individual? Then we can also talk about the medication side effects. Are these people on different medications that, are affecting how their brain processes and their daily life? I hear on TV all the time when you watch a commercial, the side effect can be suicidal thoughts, depression, and let your doctor know. Half of these med commercials have longer side effects lists than benefits of the medication, it feels like. How is that side effect potentially affecting the person, especially for medications that they need and then have to just adjust to and kind of live with those side effects? Because maybe a medication change isn't appropriate or isn't available at that time. Mental health is also greatly impacted by the populations of close family members. Our spouse is sick? Are they passing away? How many people have their children pass away before them, or they're trying to take care of their grandkids and adding extra stress onto their lives. These elderly population, those over 65, may also be seeing a decline in their physical health. This can mean a loss of independence, a loss of their previous roles, habits, and routines. And as an OT, loss of independence, roles, habits, routine, that's my bread and butter. We work within the self-care world, what do you want to do rather than, and what you have to do rather than what you should do. And so that's where, like, as an OT, I come into play a lot. And then also, these individuals may be facing isolation. We chatted earlier about how they have harder accessibility to even go and see doctors, especially for those in the community who cannot drive. But that's the same for also friends. Are they able to go and see friends if they don't have a license and there's no public transportation? How are they getting into the community? How are they getting groceries? Are now more reliant on other people? Well, there we go again, that loss of independence. There's also a loss of familiar peers. I don't know about you, but my grandma always used to say that she'd look in the obituary every day and, who does she know? Oh, I was friends with so and so, and that was my high school classmate. That has an effect on your mental health. Not only is it just for the fact that there is a loss of life, but the fact that, you were in high school with these people. It's your direct peers who you once knew are now reaching the end of their lives, and there's a sense of mortality for you to face. There's also the social determinants of health. So, the social determinants of health are non health factors that can affect not only your physical health, but also your mental health. So, here are the big, like, six categories. And this graphic is shown for like all individuals, and you can look at it. And we're going to chat about how this directly affects the elderly population. So, for employment and income, they're often retired and then on a fixed income budget. So then when you have rising medical expenses, especially as health may begin to decline or you need more support, what's happening to that fixed income? You may see increased stress because the little bit of extra money you had prior may be now dwindling, and your medical bills may be rising up. And like we already said before, there is so much medical debt happening within this population that's weighing on not only their minds, but then it's contributing to all their other health factors. And what kind of support are they having? Some people that I see, like, they're helping their kids who are going through a hard time, or they're helping their grandchildren. And, when you think about this population, they have a lineage. They are not that 30-something-year-old single adult who is focused on growing themselves, but they have often families and grandchildren that they're thinking of, and they want to leave a legacy behind for them. And are they able to at that current time? And how is those thoughts impacting that mental health? And, sadly, it often creates a larger challenge for it. And then we look at like their neighborhood or the physical environment that the individual is living in. What does housing look like? Not only where is the house in the community, but what does the house physically look like? Does it have stairs to enter? What does their bathroom look like? Do they have to step up and over a bathtub, or is it just a walk-in shower? Is their bedroom on the second floor? And as they might have arthritis and their knees ache, and what's the challenge to get to the bathroom every day? And then can they still even clean their house? Are things piling up and they say they like it like that as almost a distraction for the fact that maybe they suffer from the inability to keep the house in a cleanly order like they once did. And as, maybe the inability to clean, maybe their mental health is then going down and they become that apathy and that not wanting to clean, especially with things like depression. Those symptoms can cause, the sadness and the tiredness. And now all of a sudden they don't even care what their space looks like, especially in those who don't have that support system to then come and help them clean it up. And what's the transportation like? Like we were chatting about, how do they still drive, or have they given their car to a family member? Who's helping them get around? Many of these rural areas do not have safe walkable areas, or if you did have to walk, you're maybe walking miles. I know from where I grew up as a child, in another rural community, like, we didn't have sidewalks. And when I moved to my current house, I was like, look, mom, there's a sidewalk. If you've lived in a rural community, sometimes that can be almost like an excitement itself, is that you have a walkable area. Um, and then we have education. And while this might not greatly impact the day-to-day life of an elderly individual, it definitely goes on, and just has some like lasting things. Like, what is their literacy? Is this individual able to read as a pastime or understand maybe the new medication paperwork and signing things at a doctor's office, that kind of health literacy? Then we have food, the access for food and the accessibility to health options. Many rural areas are actually a food desert, meaning it's harder to get healthy food, especially if they don't have that transportation. Uh, and then are they able to keep their fridge clean and get in new food? Many of these individuals that I see say they kind of forgo lunch. And in deeper conversation, uh, it's not always because they don't want lunch. It's often because they don't have the ability to always have access to lunch. So many people may be reliant on microwaved meals or options like Meals on Wheels, where they're coming in and providing maybe one meal a day for them. And so then they're kind of on their own to like get those two other meals. And then when we think about microwave meals, I mean, what's the nutrition in that as well? Are they able to use the stove or use an oven to prepare homemade nutritious meals? And we know that nutrition has such a direct impact on people's overall health. And then we can chat about just the community and social contexts. As like we said before, they may be facing the death of peers. They may know people who are going through the end of life, and maybe they're not able to even get out and go into old social organizations or participate in things like church or knitting groups like they once were. And how does that social integration affect them? Well, it's causing isolation, right? They're being more reliant on maybe that core family group who's there to help them, or core friend group that's there to help them, rather than being integrated into the larger segment and part of their community and family. Then we also just have, in general, the healthcare system. I don't know if you've ever gone to a doctor before, but the healthcare system can be very hard to navigate. As my career, I work in the healthcare field, and I myself, who is literate in healthcare, can find it very difficult to navigate through, whether it's helping family members or even just myself going to appointments, scheduling appointments, knowing from what one doctor said to the other. There's a lot of weight on the individual to be their own advocate and to kind of piece everything together, as our system is not always fluid. It can be kind of feel disjointed at time. And that's not even talking about health coverage and then having to worry about who is in network or what provider is out of network, and trying to find all of that while maybe you're having, like we talked about, that your brain is actually changing and those neural pathways might be causing slower thinking times, and you're needing to then think on your feet and advocate for yourself. And then let's throw on top of it, you have any condition that you're now worried about, your blood pressure or your heart condition, and then you're facing those mental health challenges. Can we see how this is all compounding, making just even the simplest of tasks of going to a physical becoming almost inaccessible and harder for these people to go to? And then, we have the provider inability, like the providers are not there, they're not accessible, they're not available for them to go and get the help that they need. Um, and then how does this affect everything? Well, it affects their health outcomes. It can lead to increased mortality rates. It can increase morbidity rates. You know, Overall, these people may have worse health outcomes because there's so many different challenges just within their daily life to access um, good overall health if we look at it as a whole, well-rounded in that quality of life. And then you can really apply this graphic to anyone that you know and think about that individual, especially when we think about people on that individual level. This obviously looks at it more as a systemic or a group, and that's what we're chatting about today. But if you're working one on one with a client, you can kind of go through this in your head and think about how every single category is affecting that overall health and overall mental health. What is that doing to a person to worry about all these different layers? You know, yeah, they might be depressed and they might be sad because they're so stressed and there's so many things for them to worry about. Now let's add on trauma, a whole other category of things for this poor person to worry about. So this is talking about the adverse childhood experience, which is a test that can directly it's a test that looks at the number of negative childhood experiences that an individual may face. And the ACE test has supportive data that a higher score or higher, more negative childhood experience that you face can directly relate and impact someone's not only physical, but mental health problems. This can lead to behavioral problems. We may see this individual um, working with risky behaviors, and all of that obviously then affects overall mental health and overall health in general. So, the adverse childhood experience directly looks at what happened in this individual's childhood, which for the elderly population, um, they might not remember if they have like a diagnosis like dementia, or they may thought it was, you know, more like normal back then. So was there physical abuse going on or emotional abuse? Was there physical or emotional neglect? What was happening within their household? Um, Many mental health challenges are genetic. Was someone else in their family dealing with an undiagnosed mental illness? Or were other people incarcerated or facing domestic violence? And all of these compounded are going to lead to um, challenges later on in life. So we have not only then, we also have like at the graphic on the bottom right, for me, it talks about right the whole conception of trauma itself within the individual's childhood. So that comes from like generational trauma. Is there systemic things that had happened in the society that the individual faced that is leading to compounded trauma being passed on from generation to generation? And then how does their social conditions that they were in, or the social mental health that we were chatting about in their childhood, affecting their health? And then what adverse childhood experiences were they facing? And how did this then develop who they were today? Were these people, did they have any social, emotional, or cognitive impairments, or were they adopting high risk behaviors? And then how did they move through it? And could that be possibly contributing to the disease or disability that we're seeing with them today? And then, that's really where we're coming in, and we're trying to work with them to prevent that early death. Like, what can we do to make their life better today? Improve that quality of life to hopefully prevent, the idea of an early death. And obviously, we're not always directly impacting that, especially if the individual had partaken, like, maybe excessive drug use or just the habit of smoking. Those have like physical changes to the body that we might not be able to intervene with, but how can we support them having the best quality of life today in prevention for that early death? Talking still about trauma, there's three main types of direct trauma. So you have acute trauma. So this is a single extraordinary event that leads to the individual feeling powerless. So, in cases for that I see or that I work with, this might be an individual who had a fall at home. I work in a subacute rehab and skilled nursing facility. So sometimes I will see individuals who come in for a fall at home, and they will discuss that they laid on the floor for hours, sometimes days, even before they were found by somebody. These people might say um, that they thought, like, they just had kind of resided themselves to death, and but we're still holding out, for some hope that someone would find them. That is a traumatic experience. Not only is just falling in general very scary, but then to not have the strength or ability to upright yourself to move on from it, let alone if there is then a broken hip or a broken arm or major injury that happened in that time. We also have chronic types of direct trauma. So these can be exposures from varied or multiple traumatic experiences. Um, this can be just neglect in childhood, going back to that ACE score. This can also be things that they face within their adulthood, or even, going back to the idea of falls, multiple falls. If they're, continuing to fall again and again, and maybe they're going to a rehab and going home and they go and they fall again, how is that almost inability to trust your own body to keep you upright and safe, how is that affecting that trauma response? And then we have things like complex trauma. So these are usually multiple traumatic prolonged events, which can be like long-term domestic violence, or in regards to our like veterans going through war or just civil unrest. And how are those experiences then directly affecting overall mental health? And I love this graphic on the side, the trauma response. So anyone who goes through a trauma event has a trauma response. And I feel like we all are pretty familiar with the main two, right? Fight or flight. But there's really four main ones, which is your fight, flight, freeze, and fawn. So if we look at it in regards to, let's say my patient who's had a fall, the individual who has the flight response, they might, when we try to go and stand and we're working on maybe like getting on pants or going into the bathroom, they might try to, uh, nothing might be right for them in the sense of wanting to do it. Oh, I need this first. I need that first. They might have symptoms and signs of anxiety, and they might be like trying to almost distract from doing the task itself. And they're trying to make sure everything around them is perfect before they want to try the task. Then you might have someone who has the fight response. This can be that anger outburst, or they want to control everything that's going on. They're saying, don't touch me and I can do it. And they almost become, where we often might even label them, combative when we're trying to go through that trauma event again. We have individuals who freeze. You're asking them to stand, and they're like, well, I can't, not right now. And they're almost like they're stuck. Maybe they want to. They're like, yeah, I'm going to stand. And they go to, and they just, nothing's happening. They're literally freezing at that reminder of the traumatic experience. And then we have those who have fawn, which I was the most unfamiliar with when I first started doing research years ago into trauma. Um, but like, at least for myself, like, this is where even I see myself for any traumatic thing when I get overstressed. It's that people pleaser. This person may be wanting to make sure that you're taken care of rather than themselves. This person may be very hard to self-critique. uh, when it comes to that example of standing, this person might say, oh, I'm too old to do that, or I'm stupid, I'm too weak, and oh, let's not even try it today, there's no point in it. And so all of those things come down is because, as a clinician, I am asking someone to stand, right? We had that acute or maybe chronic direct trauma of falling. Now I'm asking you to stand where I'm in control. I've decided what we're going to do. You now may feel powerless. When you feel powerless, what's happening? We're going back to the feelings of the traumatic response. Therefore, I'm seeing in my practice that trauma response. And so, what does that mean? What are we supposed to do? Well, before I think we can even get into how do we directly care for people with a traumatic history, how do we care for the elderly in general? And this is where the 4M framework kind of comes in. And it's one of like my preferred frameworks that I pull into my practice. And I think a lot about when I'm seeing patients. Um, let's not chat about the first M, because it really, really bothers me that it's what matters and not a direct M. But I didn't make the framework, so I guess I don't get to complain about it. But the 4M framework looks at what matters to that individual. looking at that person as just a person-centered, client-centered approach. What does this individual want out of, especially like the end of their life when we're meeting them? What kind of goals do they have for themselves? And then, as an OT, I don't really deal with the medication as much, but I do collaborate with nursing and chatting with others and looking at their medications to know what are those side effects that could be happening and making sure that we can make the medication based on what matters to them. What do they want out of their healthcare? Then we have mentation, and that is all about the prevention, identifying, treating, and managing of not only cognitive disorders like dementia, but possibly depression and delirium across the setting. And how are we doing that? By focusing on what matters. We're addressing the mental health by making sure we're looking at an individual as who they are and not just as diagnosis and symptoms and what they can look like on a piece of paper and in documentation. And another way we can do that is by mobility. Of course, in a perfect world, anyone over the age of 65 would have no equipment, would just be walking around doing as they want. But sadly, that's not the truth in the world we live in. Therefore, what can, this is really like physical therapy and occupational therapy are coming in and not looking at that mobility. How can we make them as independent as possible with whatever mobility they do have, whether that's a rollator, a walker, or a wheelchair? So that way they can, again, go back to doing what matters. And once we kind of start looking at the elderly as a true client centered individual approach, it makes addressing the social determinants of health, the adverse childhood experiences, and any trauma that they face a little bit easier. Because when we look at trauma informed principles and values, we can see that they kind of directly relate to the individual. So this one here kind of, looks at the overall generalization of the principles and values, but I want to talk a little bit how we can integrate it with the 4 M's. So if you have a client or a patient and you go and you talk to them and you're going to understand first about what matters. Well, already this is collaboration. You as the clinician is saying what matters to you. We're going to collaborate together. And then maybe you leave from there and you can talk to your whole interdisciplinary team about what is important to that patient. And if we're all doing that in a larger setting, then we all are collaborating to find out what matters to that person. And then we're starting to work on to the choice where we're now kind of, yes, there's things we have to work on. If you have a fear of falling, that doesn't mean we're never going to work on standing again or like, getting maybe on and off a toilet again. But, how can we do it? Where can we do it? Is there a place that they feel safe? So now we're giving them that choice that is available to them, and then we're building that level of trust. They know that we're here to help them. That's why, we all go into healthcare. We want to help these people. So when we're giving them choices through collaboration, working on what matters, we're building trust. And we're also ensuring that they feel safe. We want to create that welcoming environment. We want to make sure we're creating a place where they know that they can trust us, have choices, and that we're going to collaborate with them. And all of this really leads to empowerment. We're making these individuals feel like there is a sense of hope or possibility for a higher quality life than what they're currently dealing with. And while we might not be able to, cure their mental health disorder, right? Because it's a chronic condition, or we might not be able to even cure some of their physical conditions that they have going on. We're now at least working to make them feel that we're all in the same team for the betterment of them. Um, this is a study that I found, and it was looking at how we can integrate the kind of trauma informed responses and domains into a long-term setting. So this can look like not only long-term, but I think it's pretty applicable to almost any setting that you're in. What can you do to train yourself such as coming to an education like this today, or train other staff for just the recognition of what trauma could look like. Realizing that trauma does not happen in isolation, that it can affect every single relationship and part of someone's life. Um, then how are we responding to it? Are we doing some problem-based learning? Is there a way that you can look at case studies or just overall increasing your confidence in your ability to respond to an individual with a traumatic past? We want to respect the individual, and we're working to making sure that, like, not only ourselves but maybe the company we work for, or where we have power, and maybe just talking with our coworkers, are respecting all things about trauma. And then knowing that when we're looking at what matters to the individual, we're kind of creating resilience. This person has lived 50, 60, maybe 70 plus years with everything that has happened. They are resilient. They have the fight to keep going. Maybe we just need to collaborate and empower them to find it within themselves if they're having trouble with that. While I was doing my research, I came across the World Health Organization I Cope movement, which I was unfamiliar with before this, but it's kind of just they have a whole bunch of different little handouts like this, and I just included some in here. And what these are looking at are, what can not only healthcare workers, but, social care workers do to support the person. And I encourage you to look at the I Cope uh, tab and like website with the World Health Organization for further information. And I thought it was really powerful. So when it comes to social care and support, um, 1 million people over the age of 60 are estimated to be care dependent, meaning they rely on someone else to do all of the care for them. When you think about how that impacts someone's mental health, because once upon a time they were an independent individual, most likely, how is that affecting them? What can we do to bring back the choices, to bring back that collaboration? Even if they're fully dependent, what can we do to make them feel like they are still in control of their own lives? We talked about that trauma is about feeling helpless, it's about feeling powerless. So, as providers, as clinicians, we really want to support and provide choice and give back every little bit of independence that we can for the person while still making sure that they're being safe and taken care of. When it comes to depression, we can keep out a lookout for their mood. We can, there's different assessments that we can do. How can we encourage participation? Knowing your local area, knowing what resources you have available is probably one of the best bets. Um, yeah, I know there's people from like all over New York, so I just kind of kept it vague in that sense, but really look into your rural community. Is there any home interventions, or is there, online spaces that maybe we can help them navigate, where then we can encourage social participation. We can then encourage maybe just even calling of a friend to help combat maybe depressive symptoms. We have cognitive decline and dementia. So the rise and then the numbers of those who suffer with dementia worldwide is on the rise. So what does this mean? Well, we know that the brain is ever changing, and these people are now dealing with a cognitive decline, and sometimes sadly they're not even aware of it. So we want to make sure that we're not only keeping them safe, but we're fighting some reversible conditions: dehydration, delirium, maybe medication side effects, or infections like a urinary tract disease can lead to a change in cognition. And if those are being kind of monitored, taken care of, and worked against, then it creates just a real baseline and easier way for us to then address the individual at that, individual client-centered area. Can we offer them some sort of cognitive stimulation or exercises to just help keep them moving, keep their brain active, that they're, they're not just sitting there staring at nothing, especially like in homes. If we go back to the social determinants of health, do they have limited money? Are they then having maybe difficulty affording cable or affording streaming services, where now they don't even have that to sit and watch TV and just engage in something? Or, can they no longer read books like they once do? And how can we kind of adapt the things that they like, going back to that, what matters to them, to then keep them cognitively stimulated? And then, you know, these people have often family. Yes, there's cases where the individual is fully alone, but the majority of the patients that I see have family, whether that is distant relatives or whether that's friends or neighbors. They have support from others, and they're not alone in isolation within this. So, what can we help the caregivers go through too? For many people, if it comes, if the elderly person is their mother or their grandmother, they have watched them change. They've watched them lose that independence, lose the roles they once were. Maybe they've also lost family members along with their elderly individual, and now this can be hard on them too. So when, especially if your elderly person maybe had a ride brought in, they're brought in by their daughter sitting there, or their son is sitting there, including them in the conversation and working with them as a whole to find out what matters to the whole, maybe family unit, can best support them in going through all of these pretty hard changes. And this can include offering advice, counseling, coaching. Maybe they need special training to best take care of their individual. And it can also just be doing, like, maybe getting them in touch with services that can arrange for respite care. So I'm going to open this up to questions here in a second, but to just kind of close this little out, I want you to know that collaboration is key to well-rounded care. We do not work in isolation. An individual is not sick or facing some sort of challenge in isolation. And more importantly, mental health care and mental health support does not happen in isolation. Every facet of someone's life directly impacts their mental health concerns. And it is our job as providers to be aware and work to support this. Yes, as providers, we are facing so many challenges while serving the rural population. There's higher rates of burnout within our group. There is higher rates of, we're seeing more patients than ever before, and there's pressure from our bigger companies and insurance companies to get things done fast and to almost mill them through. But we need to make sure that we're on the right side of the statistics. Don't be an individual who lets someone fall through the cracks, and do the best that you can while still supporting yourself to support and empower all of the challenges that our patients face. Collaboration and choice is such a strong thing that we can give somebody, even if it feels small for us, just that extra second of saying, would you rather work on strengthening or self care today, to just let them feel a little more like how they used to. And I would love to answer any questions that you guys have. And thank you so much for your time today.
Thank you, Kately. And we have a small group, so if you'd like to take yourself off mute to ask a question of Kately, feel free to do that, or feel free to put it in the chat as well. We'll continue to monitor that. But we do appreciate the timely presentation today, Kately. Thank you very much. And we'll let folks know when the recording is available as well.
Curious, I'm sorry. I didn't realize that it wasn't on. I'm curious as to what kind of best practice collaborations have you seen in engaging family members in this sort of process of recognizing and then supporting their family members. I've, seen several instances where I don't think they make the connection between, a medical condition and how it might impact, their mental health, um, or isolation and how that might impact their mental health.
I think it really comes down to family education. So I have where I work, I have a really great full rehab team where we're constantly talking about our patients with one another, discussing, especially if they're on OT, PT, and possibly speech, we're always chatting together about how they're doing or what we're seeing, and then bringing that into the families when we're seeing the families. At my facility, we meet every bit structured bit of to have a care plan meeting, and it's kind of talking there about the performance we're seeing in therapy, and then there's also activities there, and there's nursing there, and we're all kind of discussing it. And then I've noticed a lot that sometimes families just aren't aware of that connection, and so discussing, oh, in other patients I've seen this or I've seen similar things. Sometimes I won't directly say your mom has this diagnosis, therefore I think this is happening, because sometimes that can be hard for them to hear. But just saying in previous cases I've seen, this is how it goes, and letting them make those connections, I find sometimes is a little better for them to then they're like, oh, that's what's happening here. Could that be this? And I'm like, well, maybe. And then we can have that further education and discussion.
Thanks, Kaylee. Any additional questions? We do have a little time left. Questions in the chat. All right. Well, I have placed the link for the training evaluation in the chat, and I'll be following up after the training as well with folks with the link to the survey. I'll also be in touch related to the recording and when that's available too. Um, so thank you very much. Thank you for spending your lunchtime with us, and we'll look forward to seeing you at future trainings as well.
Thank you.